Good morning, everybody. I'm sorry I can't see you. You can't see me, but I hope you can hear me. It's a pleasure to be with you with this wonderful panel. Um, Integrating mental health substance use disorder care, increasing the pathways to recovery. We're going to talk a little bit about the differences and similarities that are driving our learning and collaboration as our worlds of coming together and our agencies are likely to consolidate. Each of us have a different identity that we're bringing here. Some of us are recovering people. Some of us are recovering family members. We're probably both, actually. We're recovering people and family members. And I'm going to read real quickly who they are, and then I'm going to jump into the event. So Stephanie Marcusado is the founder of the Harris Project, and after her 19-year-old son Harris died by an accidental overdose in 2013. The Harris Project is the nation's only 501c3 nonprofit committed to advancing prevention programming and advocating for the implementation of an integrated treatment model to improve the lives of teens and young adults with co-occurring disorders. Ashley Livingston is a person in sustained recovery. She is co-chair of Friends of Recovery Warren and Washington County, the local recovery community organization, which educates and motivates our communities to advocate for better recovery resources at a local, state, and federal level. She is currently working in our communities as a recovery advocate at the Hope and Healing Recovery Outreach Center, helping individuals and families to find and enhance their personal recovery. Matthew Shapiro is Associate Director of Public Affairs for National Alliance on Mental Illness, New York State. It's the nation's, which is the state chapter of NAMI, the nation's largest grassroots organization dedicated to improving the lives of individuals and family members impacted by mental illness. And I'm Harvey Rosenthal, and I am the CEO of the New York Association of Psychiatric Rehabilitation Services. I have over 45 years of experience, both in recovery and in working in the field, both as a provider and for the last 30 years as an advocate. NIAPRS is focused on improving social conditions and services and policies to promote the recovery, rehabilitation rights, community inclusion of people with psychiatric disabilities or trauma-related conditions. Okay, the first area we're going to sort of get into is what does recovery mean in our respective communities? And, I was part of a exercise that was conducted by some of our colleagues where they brought together folks from the OASIS and OMH world, and Angelie and I were part of one on stigma. And in there, what we found as we sat and talked really directly to each other is that we didn't always use the same terms, have the same services, or the same beliefs even. But we talked about SAMHSA's guiding principles, which are hope. Recovery is expected. It's person-driven. There are many pathways there, social, medical, spiritual. It's nonlinear. It's lifelong. It's holistic. Peer support is critical. It's relational. Relationships are critical to all of our work, particularly in peer support. It's very focused on cultural competence and racial equity and justice. It addresses trauma, strengths and responsibilities, and respect and dignity. For me, I'll just say, because we're starting late, I'll just say for me, as a person in long-term mental health recovery, it has always meant very much about faith and spirituality and hope and meaning and service, self-care, family, and peer support. So I'm going to turn this over to Ashley and give her a chance to comment on what does recovery mean in our respective communities.
Harvey, Ashley is not in the room right now. I don't know if you can see that, but right now it's only Matt, myself, and you. I've been texting her to see where she is.
Why don't we go to you, Stephanie, then?
Sure. So good morning, everybody. As Harvey said, I founded an organization called the Harris Project. Our sole area of focus since my 19-year-old son passed away is the prevention and treatment of co-occurring disorders, which is the combination of mental health challenges and substance misuse and addiction. I kind of have a slightly different lens than a lot of people in this space, which is I believe that hope and faith and all of those things are critical, but even more critical is access to treatment that can actually address the person. So, you can't expect somebody to enter a system of care that doesn't meet their needs and hope that they will do well. I always say that you shouldn't have to be lucky to make it out the other side, that those who do often carry guilt and wonder how it is that they made it out when so many of their friends, their colleagues, their peers have passed away. And so for me, a hopeful system that leads to sustainable recovery and recovery in whatever vision a person has for themselves is only achievable when people can access a system of care that meets their needs. So that's kind of like how I frame a lot of this out. And I know Ashley's here now, so I could go on longer, but I want Ashley to kind of take her spot in the lineup.
Thank you, Stephanie. Ashley?
All right, can you guys hear me?
Yes, and we can see you too.
Okay, perfect. So I'm Ashley, and I'm an individual in long-term recovery. For me, that means that I haven't used a mood or mind-altering substance in 8 years, and I'm an individual with a dual diagnosis, so this is very near and dear to my heart. I'm also co-chair at Friends of Recovery, Warren in Washington, and I work as a recovery advocate at the Hope and Healing Recovery Community Center. And so why I think that this is so important is because as a peer, I continually watch my people get bounced between the two systems. I forever get frustrated, right, when I hear an addiction treatment center say, oh, well, we can't take this individual because, you know, they're feeling suicidal. I don't know about anybody that's out there. You know, when you've went through withdrawal, if you haven't felt like dying, I don't fucking know, right? Because I know that I wanted to die when I was going through withdrawal. And then we also have, you know, mental health places that say, oh, you know, like they need to have 6 months of abstinence. And if you were on the earlier panel with Rob, you heard him say, right, that it's not your path. And so recovery can look very different for everybody. So that's why this is near and dear to my heart, because I truly believe in celebrating and elevating all pathways, and meeting people exactly where they're at and not having them get, you know, ping-ponged between the two systems and then eventually just lost.
Like, since this was my spot now, because I believe in everything that Ashley's saying, I do want to kind of ground it in my story, because I know that Ashley does such a great job of sharing hers, and my story is really my son's story. And I want you to envision a young man who's a senior in high school who had received services for his mental health throughout his life, first an anxiety disorder and then ADHD. Not one mental health professional ever said that a young person like him, popular, social, athletic, that he might navigate to substances as a way to cope and manage, to self-medicate, not to party, but to look to be able to go to the party feeling comfortable in his own skin. Now, fast forward to that young man who is now a senior in high school, had been seeing a therapist, was on medication for the first time, stopped seeing the therapist because he was doing so well, right? We thought like rear view mirror, like life is good. And when his anxiety disorder overwhelmed the medication, he navigated to prescription medication. And then he entered the traditional rehabilitation world, was kind of parked there for a month and a half, and, you know, was in the groups and had to remember what life was like before substances, but ultimately came home. And I was the person who took him to the intensive outpatient program. I took him to the psychiatrist. I took him to the psychologist. I took him to the 12-step meeting. I took him to the gym, and he had a recurrence in use within 2 weeks, because each of those different things were not a comprehensive, integrated way to address what he was going through. He wasn't getting the skills he needed. He needed less services and better design services with the same paradigm, with a way to support him. So I just want to kind of ground my perspective in that space, because a year and a half later, my son was dead. 4 inpatient substance use programs, 2 outpatient substance use programs, 1 short-term mental health inpatient. Everybody said he had co-occurring disorders. Everybody said he treated it. How did he end up dead? And so that's why I kind of commit myself to this work. Matt,
you want me
you're up.
Okay, I know if the patients are going. Well, thank you, Stephanie, and good morning, everyone. It's really a pleasure and very important for me to be here. even though I do work for NAMI, my family has been impacted both by mental health challenges and addiction and substance use issues. Last year, I lost my older half brother, Alan M., who had faced addiction issues for most of his adult life. He was considerably older than me, in his 60s, and years of abuse led to chronic health issues. He had a stroke, which took his life. And then I have my younger brother also had opiate addiction, which he developed after having neck surgery and got prescribed pain medication, which he eventually became addicted to. And in talking to him afterwards, he had a very dangerous 2-year journey where he was taking pills, and his my sister-in-law finally figured out what was going on. And when we stepped in and tried to get him help, we were lucky when he finally opened up to me. He talked about that he was really using it to deal with other issues in his life, anxiety issues, depression issues, that he realized he was using the painkillers more for those issues than. Does someone not have a mute on? I hear like an echo. I'm sorry. I don't know what was causing that. I still kind of hear it, but that's okay. So, we were able to get him a good therapist to deal with his issues and his depression issues for what he was really self-medicating for. And, it was very interesting. Literally after my younger brother had surgery, I had back surgery and also got prescribed painkillers. And, I'm lucky I didn't become addicted. And I've come to ask myself, well, it runs in our family. My older brother has dealt with these issues for over 50 years. My younger brother has these issues. What was different about me? How I didn't get addicted, and why I never quite have the answer to that. I really think that one of the really positive things in my case is that I was already addressing my mental health. I was already seeing a therapist. I was already seeing properly prescribed medication to handle my mental health issues, which are ADHD. It sounds a lot, I hear Harris's story again. You hear so much of mine, and I'm very lucky. I was diagnosed at 3.5 years old and have been in recovery, for most of my memory, most of my life through childhood and adulthood. Embracing recovery. I really think that kept me on a separate path than what impacted or inflicted my brothers with. So, to answer the original question, what is recovery? To me, in facing, I think mental health and substance use, what recovery is actively being engaged in treating or addressing your issues, whether through therapy, through medication, through friend support, that you're active in addressing these issues, and with me dealing with my mental health, I know when I'm struggling, who to talk to and where to get support. And I think, to me, all the things that Harvey said, that he's embraced spirituality and family support, and Ashley too, as the three of us active in our own recoveries. And I know that can be different to each of us, but I think accepting, to me, what recovery is the problem or the condition. I don't want to say problem, but the condition, and then actively working to address it. And it's an everyday process. It's people say, does recovery ever end? It's a journey. It's not a destination. Ashley, Harvey, and I are going to be working on our recovery, till the day we die, because that's what it is. It's a very active process. It's not a destination. What's really important is that it's an active process that you're engaged in to address your own set of circumstances.
So I see that Harvey's not here. So I'm going to maybe transition us into the next question, just so that we can, but I do want to say that only with our mental health do we not view ourselves as consumers. And by that, I mean, if you tore your ACL, you might go for like 2 or 3 opinions before you decide what pathway you're going to take. With our mental health, we tend to get a name scribbled on a piece of paper. We're told to kind of go see that person. And if we don't start feeling better, we start wondering what we did wrong. We don't think, well, maybe that person isn't using evidence-based practices. Maybe that person, because, when you're seeing a therapist, you've got to have also a personal connection. With surgery, bedside manner, not so important. You just want to get the person who's going to get the job done. But here you need to have that therapeutic relationship, that way to support one another. Harvey, I see you're back, so we're transitioning.
Yeah, I would like to say a couple more things personally. I sort of gave the 50,000 foot. From my own recovery view, I was first diagnosed with anxiety and depression, had a very severe depression, very flat, wasn't able to really function, very isolative. Took me years. Eventually, this work is a calling. Was able to come up to Albany and do this work. Saw a mental health system that told people they couldn't recover, they couldn't work, that it was all about medicine and broken brains, and you would be in services for the rest of your life. Like so many others who had a personal experience, I rejected that and have always worked towards, with dignity and choice, and hope that everyone gets to recover in their own way. But I want to add one last thing. I was in psychotherapies of different kinds, and you name it, all different kinds of talking therapies. But it wasn't until I was also seen as having an addiction and wound up with an addictions counselor that things came together, because there was a clarity and an accountability, an explanation for what was going on with me that was well beyond anxiety or depression. So I have a lot of gratitude for having an addictions counselor. None of that would have been expected in my family, but it's made a great difference in my life. So I just wanted to say that. The next question, I think, is, let me see here, has to do with, I'm just going to get at my sheet of paper here. It's been quite a ride this morning, hasn't it? Okay, prevention, treatment, and recovery. So what do they mean? Those are terms in OASIS. They're not as familiar in the way that they're represented there in OMH. I think Ashley has the first comment here.
So I guess for me, right, prevention is sort of, I don't know, like, I think that they mean two different things when you talk about OASIS and you talk about LMH, right? And I see a lot more being done with, sort of like LMH than I do. Well, I guess I see some with OASIS, like the Too Smart for Drugs. But like what I envision, right, is, you were talking about, Harvey, like, and I hope you don't mind, but you were talking about until you met with both, and you really didn't understand. And so it was when you met with that, prevention, or that treatment provider. So for me, I think like we should be doing more in terms of what is mental health? What does it look like? Are you, so, and Stephanie can talk to this too, like, are you predispositioned to be addicted? Because I can speak for me, like I won the DARE contest, and yet I became, right, an individual that struggles with an opioid use disorder. And kind of like you were saying, Matt, you talked about your brother. Like for me, I didn't really realize that I was like predispositioned, and it really doesn't matter, right? Like we can all take the same substance, but our brains are going to metabolize it very different, and we can't control how our brain metabolizes it, period. And so, for me, I think really being aware of, the neurobiology behind it, understanding what a mental health diagnosis is, things like that. I think like that would be really good prevention. And then treatment, I think that's self-explanatory, right? But like I said, we really need to kind of puncture the holes into those two separate silos, because I really think that when we can get, our mental health and our substance use treated simultaneously, that creates a better outcome, and maybe not having to go to like 50 different places. And I can speak from a place in treatment court. I was mandated to do mental health counseling, domestic violence counseling, because I'm also a survivor of DV, which is how I got addicted to begin with. And then treatment, plus like a whole plethora of other things like community service and life skills. So, for me, I think, having that one place where we can walk in and sort of get that. And, Steph, you touched on the relations, right? And sometimes I know people that jive better with their counselor at their, mental health counseling than they do with the, individuals at their treatment. So why not have like one individual that is, licensed to do all of it, and then I think that the outcomes would be better. And so I'd also like to stop seeing people get denied for mental health conditions to go to treatment places like benzodiazepines. I heard somebody touch about anxiety. Like benzodiazepines are seen very negatively in, the addiction world as opposed to the mental health world. So I just think there's like a lot of room for us to really take a look at these systems. And there's a lot of failure. And then recovery. I didn't really realize this until actually sitting with these great individuals that are on this panel with me, that mental health and addiction view recovery very differently too. And I kind of love that mental health has sort of grown a little bit more and maybe faster than the addiction world. So, like what person-centered care, talk about it. I really would like to begin to look at that, right? Like, what does recovery mean? Is it, self-defined? Is it, your pathways and putting all of these multiple things together? But I just think that, the mental health side is a little further than the addiction side. And so for that, I'm super grateful. And I look forward to really coming together to define that. But I really think that you're in recovery when you say you are. Your recovery can look like whatever the fuck you want it to look like, because it's yours. So.
Thank you very much. Stephanie, you're up.
Sure. So I'm going to take the back it up for a second. So for me, my background is I'm an attorney by training. I was a PTA president. I was on the school board in my town in Westchester County. We would bring in the programs and we would feel really good. Like the speaker would come in, everybody clap. We're like, oh, great. We checked the box. Everybody's feeling terrific. When Harris died, I thought, what is it in the prevention space that could make a difference? So we're all watching what's going on in this COVID-19 world. We're talking about completed suicides. We're talking about overdose. We're talking about alcohol-related deaths, but they're typically separate conversations, right? And when you bring a mental health program into a school, you are traditionally talking about things like, oh, mental health matters and, mental health awareness, but nobody really says, why does it matter? So it matters because when young people don't take care of their mental health, they learn to find ways to cope and manage. And they often navigate to things like substances. So we actually created, no OASIS or OMH funding because really we don't fit into either camp. We created CODA, co-occurring disorders awareness, really empowering our young people to understand pathways to substance misuse and addiction, to really talk about the link between their mental health, trauma, and addiction, to talk about the risks of even, getting prescribed medication for a sports injury or your wisdom teeth being removed, or what the genetics and family history look like. Because as much as we think that our young people today learn things in 30 seconds, they are craving concrete information, facts, and information that can kind of guide their decision-making, how they learn how to connect and support each other, knowing how to link to resources. So these are concrete things that we're doing. We have CODA awareness games, we have youth summits. We're really engaging our young people in the future of recovery, because the earlier you enter a proactive evidence-based system of care, the less likely you are to become so complicated that it's hard to unpack what you have going on. And that kind of leads me into the treatment piece of what we do. So, you go in and you're presenting and you're empowering young people and everybody's feeling really good, but there's a certain percentage of the young people in the room who already have co-occurring disorders. They're now self-identifying. They want to know what they can do about it. It was, I co-chair the Westchester County Co-occurring System of Care Committee. I kind of lead this co-occurring movement in the Mid-Hudson region. but it was very hard to kind of piece together the pieces of what people needed. And during the pandemic, we got funded by WMC Health, and we brought in evidence-based treatment for 12 to 29-year-olds with co-occurring disorders. Treatment does not mean, as Ashley and I will say ad nauseum, going to a million different places and being in really intensive services. The right service delivery model, like what we have in Encompass, is a once-a-week therapy that is individualized, that incorporates motivational enhancement therapy, cognitive behavioral therapy, contingency management, and pro-social activities. We are building sort of a system of fun, healthy things to do. We're working with Friends of Recovery. Like, we're partnered with Westchester County, the Department of Community Mental Health. Like, you can transform the system to allow people to navigate their pathway to recovery in a more seamless way. And then recovery happens because people feel okay about going to get help and support. People feel confident not having to be anonymous in a space to be able to only share amongst those that they feel safe with. The whole community becomes a safe space. And so to me, like, this happens when you tear the veil down, when you bring together systems that belong, working in collaboration in an integrated way. So that's kind of my long way of saying there's a lot of positive stuff that even those of you throughout the state who are on can start doing within your communities to make a difference.
Thank you, Stephanie. How about you, Matthew?
Yeah, no, thank you. And you know, I think both Stephanie and Ashley kind of touched on what's so important, that person-centered approach. I mean, we talk about in the mental health side, you know, you see one person with schizophrenia, you've seen one person with schizophrenia, you know, it's not, or ADHD, depression, whatever it is, you know, no two cases are going to be the same. What works for one person doesn't necessarily work for another. And that's so important to understand too, obviously, when we look at substance abuse, that you have to look at the whole person and see what their specific set of issues are, their struggles, their challenges, and then put together a plan that's tailored to them and treating them holistically. And that's really the key. Everything that we want to see is tailored to the person. It's not a check off where, you know, they have this diagnosis, they must need this medication or that type of therapy or so forth and so on. It's really, you know, earlier when Stephanie was talking too, I believe it was Stephanie was talking about, it might have been Harvey, you know, building that relationship with the therapist. You know, that's really what it is. It's a relationship. The therapist really has to get the person as an individual and what might work for them, which might not work for other people. So really, the most important thing that we need to talk about is treating holistically. And that's not going to happen when you're getting your services all over the place that, you know, maybe and the left arm might not know what the right arm is doing if you're lucky enough to get both, you know, substance use care and mental health care. You know, Ashley talked before how challenging it is to get both, because once you're labeled with one, it's so hard to get services for the other, and then treating the whole person and make sure that this is being done holistically and that every, you know, component of this recovery team, you know, in the NAMI world, we talk about recovery teams as, you know, the individual, their provider, and their family working together, or friends, or, you know, caretakers. But, you know, again, this, you know, when you're talking about different type of therapies and professionals who might be needed to guide your recovery, that it is looked on as a team, has open communication, shared goals, shared understanding, and really that the individual is in the driver's seat of what their goals are and what their are, and understands that. So that's really the most important thing, is having this holistic approach that treats the whole person, that all the pieces of the puzzle are working together with open communication and shared decision making and shared goals.
Thank you, Matthew. I'll finish up on this segment. First of all, I just want to say that after all these years of working to promote recovery and being in recovery, the one goal I feel that I try to support is freedom, that people be free from the scripts they've learned, from the limitations they have, from poverty and discrimination, from incarceration, all the things that plague us. But, it's not employment. It's not symptom management for me. It's a greater sense of freedom. Anyway, getting back to prevention, I think someone mentioned it in the chat box, but we have a number of tools in mental health that maybe the folks have over on in the addiction world as well. And that's wellness recovery action plans, which were developed by Mary Ellen Copeland. They're a whole sort of program where you identify what your strengths are, what your needs are, what your patterns are, what your red flags are, what to do if when things are breaking down, what's your support system. So many people throughout our system, staff and people who identify as in recovery, it's a godsend. We also have, the thing I want to pay attention to also that affects both mental health and addiction are the new programs that are coming out jointly from OMH and OASIS. And that one of them is called crisis stabilization. And I think that's really critical as a prevention of things going worse, being admitted, going to the hospital, getting arrested, engaging in overdose or suicide. And that's a program where you can be taken voluntarily. Hopefully you go voluntarily. And it's multidisciplinary, and you're there for 1 minute less than 24 hours for whatever reason. And you're going to get really intensive support of all kinds, and there'll be peers there and a way to really help you come out of it so you don't wind up in that cycle of being a patient in a system or in a prison or in a jail. Another thing is what's called CORE. And we had something called Home and Community-Based Services, OMH and OASIS, but nobody could get to them. They were too complicated, too much paperwork, too many staff involved, too many approvals. So the state has simplified it, and in February, OMH and OASIS are rolling out these core services, and they're basically psych rehab, peer support, family support, and a form of treatment. And they'll be much more accessible, and they'll be much more focused in terms of treatment on the social determinants of health. We focus way so much all these years on medicine, in hospital, and symptoms and diagnosis, and to look at the person in the way that so many of you do in terms of harm reduction and the whole person and housing and employment and things like that. I will say, but one thing I observed is that OMH has so much more in the way of resources around housing and employment. And I feel for people in recovery when OASIS does not. We fund, 40,000 beds, community beds of people. And we are, working more in the way of employment. We have a long way to go. But I feel that that's so critical when you're looking at the social determinants. The agencies need to come together around that. I think that CORE is one way to do that, but housing is another really important one.
I know we're supposed to kind of have a little dialogue too. So there were a couple of things that you just said that kind of give me things to think about. One is Westchester is doing a lot in the crisis stabilization space and the 1 minute less than 24 hours. Part of the challenge, and I think that it brings it back to the topic that we're talking about here, is that it keeps somebody out of the hospital. But if the care manager, if the people that you're working with, if the peers that are there don't have the appropriate next step for referral, that's where the problem happens. So right. If you don't have access to co-occurring capable care, a single door, the no wrong door approach, that person may have touch time over and over again. So they're good for that 23 hours plus. But ultimately, if we can't get them the next step, the services they need, you only get so far. Same thing with housing. At our co-occurring system of care table in Westchester, Search for Change, many of our RCC, like RSS, many of our housing providers are there, and they're doing amazing work on the mental health side. But so many of the individuals who reside with them have co-occurring substance use challenges. And initially when they joined the table, they would kind of say like we had to keep blinders on, like sort of don't ask, don't tell. But now that we're working more collaboratively, they're finding ways to address and help and support people people without having to sort of show them the door. And so I think that it's really important for us kind of, as we think about what exists right now, we've made incredible strides, but we all know that to really, close the circle, to allow somebody to sustain their recovery, we kind of need to do more. And then finally, prevention piece, I love that tool that you talked about. We offer like social emotional learning tools for our students, because when we think about prevention, we often think about sort of that prevention early intervention space. Tier 1 primary prevention is a freaking home run. If you can get young people who are barely bubbling to start getting help and support really early, you have kind of like circumvented so much of what goes on in a sort of challenging crisis system. So that's why it's kind of like this whole continuum. So thank you for indulging me.
No, that was a great, and I just wanted to point out there are other pathways besides stabilization. You asked what's next. In the peer world, we have crisis respite houses for 10 days or so. We have living room programs for 28 days. So there are these alternative, non-medical, peer-supported programs that are growing up. I'm going to look online.
For mental health.
For mental health.
Our living room, though,
Actually, I was just going to say that. I think you're right, Stephanie. Go ahead.
Living room here in Westchester, we do. They're at our. Oh, somebody's echoing now. I think it's you, Ashley. So the living room in Westchester, they're at our co-occurring table. So even if they're funded through OMH, which they may very well be, they are expanding and have sort of much more flexibility in the support. But we want consistency, right? We don't want Westchester's living room to be really great dealing with co-occurring, but you're going someplace else and they don't really know. Like, we want to be able to, that's why a single agency is so critical, because you want to take the best of what's happening and embed it. So, yeah.
I'm going to put in the chat box, somebody's asking about CORE. Our friends down in the city, the coalition, have a copy of the OMH Oasis PowerPoint on CORE. So click on it and have a look, and you'll see how it's working. But it's so exciting because both agencies are working on that. Okay, the next question is, let me find my papers again. It's been a heck of a ride today. Okay, more specifically, what are some different pathways? Well, this is kind of a cover, similar. But are there other different pathways to recovery we haven't talked about? And does government support or inhibit these? So I'm going to go first here. And I would say spirituality. Many years, if you said anything about faith or God and you had a mental illness, you were very often going to be deemed as having some sort of religious ideation of some kind. And from the 12-step recovery world, spirituality is at the heart of it, certainly at the heart of my life as well. The shiatsu is a very important thing to me. It's Chinese medicine. So alternatives, lots of people in our world are doing yoga, are doing shiatsu, or doing tai chi, or doing Reiki in some form. And here's the problem. Government will pay for all kinds of symptom-based, illness-based, months in a hospital, and won't pay for that. So that's really outrageous. And one good thing about that is, and I'll try to find it in the chat, OMH has a pilot. We've worked on it with them. It's called self-directed care. And you get a budget, and it's thousands of dollars. That's approved by Medicaid and approved by your worker. And you know what? You can buy shiatsu. You can get yourself some clothes to go to work. You can get a computer and a modem. Or a new set of clothes if you have to go for an interview. Maybe you can fix your teeth even if the insurance doesn't cover enough. It can be a lot of money, but has to be managed very responsibly. OMH is doing a fabulous job on it. People are recovering and getting back to work, but it's that flexibility of money going where people choose, where they know what they need. I always say you could sit in a mental health program and talk about employment for 10 years. But if you gave me a couple of $1,000s to buy a couple of things that are really stopping me, that's going to get me back to work. Let me not talk about transportation and how hard that is. Help me fix my car, please. things like that. Let's see if I have anything else in this space here before I turn it over. What else about government? Well, I know that self and systems advocacy is a big way that people heal. I know that Oasis does a lot with For New York, and congratulations. I think For New York is an outstanding organization. For New York, in a handful of years, filled the conference. I forget what it's called. The big room at the Capitol, the conference center. It's an extraordinary group, and the advocacy that happens there, and I know the healing that comes from that. And that's not treatment. It's not really funded by government, but it's so important. So let me stop there and turn it over to whoever wants to go next. Ways, a variety of ways beyond services, I think, beyond treatment, prevention, and recovery, and what government can do to either make it hard or promote them. Like I said before, government has made it very hard to get to CORE. It's changing that now. But what else do you folks think? Where government could be doing more to endorse a variety of pathways to recovery?
Hi, I'm Ash again. So what I think, right, is, I'm glad that you talked about the spiritual. Faith-based is definitely a pathway of recovery, but I also think harm reduction is a path of recovery, and talk about language being very important. And I hear people say harm reduction is a path to recovery. And I say, well, whose recovery are you defining? So what I think that the government could do in terms of really supporting that, right, is overdose prevention centers. Maybe having a safe supply. Canada employs heroin-assisted treatment, and it's worked miracles up there because people are getting government grade heroin and they're using it as an approved medication, right? Just really, if you guys were in the first one, that they just started funding, that you could use funding for fentanyl test strips. Like, this is something that I think we should have been doing a long time ago. A lot of programs can't use their funding to purchase needles, you know what I mean, depending on like what the funding stream is. So I think that there's a lot more that we can do to support harm reduction as a path of recovery, because not everybody's recovery equates to abstinence, and that's okay, right? And so I'd really like to see, some more support around that. Harvey, I do love what you're saying though too, because there's some issues, like they could make laws that insurance has to cover Reiki or, acupuncture. A lot of the private insurances will, but then, Medicaid doesn't. So there's that disparity depending on if you have, state or private, and even private insurances don't pay for it. So I would like to see some laws put on that, tell insurance companies you have to see this as an approved, treatment.
How about you, Stephanie?
So for me, I'm going to go up kind of a little higher in the helicopter and get really macro for a minute. So another chunk of the work we do is in that systems transformation space. So when you think about what the government can do, so right now we're still in a space where you have to write that something is primary, right? So you're either primary for mental health and then you're in a mental health program, or you're primary for substance use and you're in a substance use program. And then, they kind of graciously allow you to write about the other in the narrative. So I think that part of what we look at when we look at true systems transformation is to look at the whole person, right? We're going to expect that there are multiple factors that impact both their mental health and their substance misuse and addiction. And how do we develop that system of care that can really address the whole person, and I'm talking about from the initial walk through the door to how you assess, to how you build a treatment plan that's person-centered, how you goal set, all of the positive strengths that you want to acknowledge, and then how you bill for it. Because right now, a lot of our providers are facing challenges with how they're going to bill. And so we bring people to the table and they kind of grab different things and kind of make it happen. But there needs to be kind of this like system that really expects co-occurring, that it anticipates ways to cope in that. And then you have, in the two spaces, professionals, clinicians, recovery coaches, peers who don't feel adequately prepared for the other. So how do you begin to sort of and build capacity and look at credentialing and kind of, create kind of tiers in what you know how to do, so that when somebody enters your door and your system, you're not only asking them about the thing that you feel comfortable with or you feel are in your wheelhouse. You are safe and comfortable asking about everything so that a person can share. Like we've had people in Westchester County, we've been doing this work for a couple of years now, where we have providers who've shared that an individual is seeing them for their mental health and somebody else at our same table for their substance use. And they didn't know that they could do both in one place, or they were embarrassed to share about their substance use with their mental health clinician. Like, we need to kind of change all of that, because if we don't support the whole person, they're not being transparent about what's going on. It's not a safe space for them. And so I think that it's really, really important from every series and set of credentialing, every series of core competency development, that both the provider of services feels comfortable with what they're doing, but the individual then, like, we shift. Like, if we can change the way we view the world, then from the beginning, people just feel much more comfortable sharing who they are. And that's how people get well, with community support. And what nobody's really mentioned, and I guess I'm kind of remiss since it's my space, is the family. So I'm gonna say it because not everybody does. In the mental health world, organizations like NAMI do such an amazing job of providing parental support and really to take away that shame and blame and whose fault is it and what you're doing. On the substance side, it is still true this day that parents are being asked to write contracts, to kick their young people out of their home if they're not abstinent, to blame them when recurrences happen. And I think that programs like community reinforcement and family training that really shift how parents are learning and loved ones and guardians are learning how to live with somebody who may be, facing substance challenges is so critical. Motivational interviewing skills, goal setting, positive reinforcement, and shame and blame comes when a system sucks. The easiest thing you can do is blame the family, is to blame the individual who's struggling, instead of looking at what the service model isn't delivering for someone. And so it's a big piece of what we do is, my young person's coming out of the hospital and I'm being told to write a contract, and if they're not abstinent, I have to kick them out. I'm sorry, if your kid had cancer and they were disinclined to go for chemotherapy, would somebody tell you to kick your kid out of the house? Like, let's shift this all. And so that's my soapbox on that one.
Matthew,
Here, kind of the NAMI family person, and it's so interesting. I love everything you said, Stephanie. And it's not just parents too. I think kind of my family story, and mentioning my younger brother. Well, my sister-in-law really struggled, and she kind of saw this like she had to institute a punitive approach to his recovery, and she would drug test him randomly, and if there was an issue, he would be punished. I don't want to get too much into details, but really teaching her that relapse is a recovery process, and that's not a failure, and because someone relapsed, they didn't fail, and really teaching those very core beliefs, not core the way Harvey was talking about before, but what we all have come to understand in this journey is so important that I think a lot of times it's even harder for spouses once they've learned that their loved one or their spouse these type of issues. They say, did I drive them to it? Do I have to try to is it up to me to fix them? And you know, that's always a hard thing as a family member. You know, when my young brother took sick, and I tried to help him, you know, I used my story of recovery to try to help him. And you know, I struggled for many years with my mental health issues, and you know, you never thought of me as a failure because you know, something we talk about a lot in NAMI and with our peers is that, you know, you can't compare the path that you're on to anyone else's path. You can't measure your own recovery based on somebody else's path. Our paths are for us alone, and that's a really important thing. And I think what Stephanie was saying before, we need to have you know, all those paths, you know, entry into all those paths, and understand that there is not a right solution. And I think one of the things that government can do, which is kind of the start of this question, is untie providers' hands. I think a lot of times, you know, regulated. You know, we've already talked about once you get a label put on you, you either G or you're MH, and there's no, you know, it's very hard. So again, we need to deregulate that. We need to, you know, I think providers only have a certain amount of options, and you know, all these complementary, or whatever you want to call them. I mean, it's so interesting with me. Like I mentioned before, my back injury, and you know, maybe one of the reasons I didn't get as addicted to painkillers is that the painkillers didn't really work for me. They didn't really ease my pain. The only thing that did, you know, I finally started going to acupuncture to deal with pain management, and it's amazing how much it actually helped my mental health sometimes more than the physical pain I was in. You know, as someone who has ADHD, a lot of times I can't shut my brain off. That's the way I explain it to people. Like I'm always going, and you know, one of the few ways to really quiet me has been those 45 minutes that I lay on the table every 2 weeks with the pins in me. I mean, that's really been a huge part of, you know, you're like, recovery is a process, and you always add new tools to your toolbox and things like that. And no tool should be deemed a bad tool, because, you know, maybe acupuncture works for me, I should have it covered, but maybe it wouldn't work for Ashley. But my provider or my insurance should bill for, you know, I should be able to bill for that if it's something that works for me. So again, I think we just need to have as big a toolbox as possible, and most importantly, have those things covered.
Thank you, Matthew. And I like that your brain doesn't stop. I've always enjoyed when you're all the things you have to say. Listen, we talked a little bit here on culture. We're not going to get to it. I want to make a left turn and get to criminal justice, which may seem racist in itself, but the overpopulation of people of color who are being arrested, shot by police, put in prison, solitary confinement. We have to stop on the front end through diversion. We're talking a lot about police alternatives. It's not about training police, it's about sending someone else. And we're working a lot on that in mental health, and I hope others as well. In terms of, there's a model out of Oregon called Cahoots, which sends an EMT and a mental health person, and they're getting tremendous results. So I wanted to say that. There is one more question for 3 minutes from Reggie saying, can you speak on harm reduction in recovery residences?
So does he want like the different models? Like, so, okay, sorry, my dog is rude, guys. Roscoe?
Hey, Reggie, you might want to be, if you have time to throw something else in the box to explain, that'd be great.
So is he saying, like, how does harm reduction fit into recovery residences? Because I do get this a lot. So actually working on the opioid settlement bill with my legislator, she was like, well, what do you mean a housing first model? So, you know, the mental health side, again, does a really good job of not booting people out when they have reoccurrences of symptoms, right? And so, you know, what we could do, you know, with recovery residences, right, is have harm reduction housing. I mean, because like when we really talk about like the social determinants and different, things that people need, right? Housing is one of them. Food is another. And just because someone is, using a substance and, so when I work with individuals, I'll just give you like a for instance. So I know an individual that I had worked with that literally he probably snorted and smoked about, I think like an ounce a week is what he was at. Previously had like lost his business and different things. So eventually we like kind of, move toward him smoking marijuana. He is currently just smoking marijuana, has just been smoking it for 3 years. He has his own business, and all of that. So like, I think like when we talk about we need to talk about the successes, because the reality is that there are some successes when individuals, use harm reduction as their path of recovery. Now, when you talk about recovery residences, if somebody's pathway that they want to take is abstinence, right? No, we really shouldn't be mixing and matching because, that can be hard for the individual, but there is an opportunity, especially with all the increase of funds. We have the supplemental block grant increase. We have the opioid settlement funds coming in. There's no reason why we can't develop new models of housing that really meet people where they're at. So does that answer your question, Reggie, or like what exactly were you looking for?
He was saying, so should there be separate housing for harm reduction? Or should it be, I don't know, the opposite is what? Should it be in every program? It would seem to be.
Well, honestly, I mean, so my legislator kind of asked me about that also, like, what do you mean? And I was like, okay, so like in thinking about it, mental health has the housing first model. You guys house them regardless if they have a reoccurrence, regardless, right? So there's not that punitive approach of taking someone's housing away. Currently, how we do it in the SUD world is you have a reoccurrence, you can be booted out. And I understand where people in the substance use place are coming from, because you do have individuals that are, their path is abstinence-based, right? I get it. I totally get it. So yes, maybe we should have, a housing first model. And then if an individual chooses upon doing that, maybe they change their pathway. Then maybe they want to change, housing levels or whatever. But yes, I do. I think that we need harm reduction housing. I don't think anybody should be put out of housing because they are having a reoccurrence of symptoms or they're choosing a different pathway. That's not.
You're focusing a lot, both of you, on getting criminalization and punishment out of addiction treatment. Am I right?
Oh, you mean decriminalizing addiction? Oh my goodness, since we're the only disease that's criminalized? Absolutely. So you talked about Oregon. Oregon had a ballot initiative. I think there needs to be some parity across their substances. As a former heroin user, I use more than a gram a day. So currently in Oregon, you can have a certain amount of substances. It's 3.5 grams with cocaine and only 1 gram with heroin. So there needs to be some parity. We actually have a decrim bill in our Senate, and also in our assembly. So I would love to see that. Honestly, yes. Because, Matt, you talked about it. That punitive approach doesn't work. Right. And we've been saying for years, we can't arrest our way out of this situation. Yet, here we are in 2021, still trying to arrest our way out of this situation. Like I said, addiction is the only disease that I know that you go to jail, right, for having like a substance on you. So if I'm diabetic and I have a shit ton of candy, and I know I'm not supposed to have candy, but I have bags and bags, right? Candy. They're not putting me in jail for having an ounce of candy.
Ashley, let's take it one step further. So now you've got, and again, I'm nobody's favorite. I am a disruptor. Then you have like drug treatment court, right? And so now here we are giving somebody sort of like the golden ring. If they can just do what they need to do in this particular treatment program, then they don't have to go to jail. Well, you know what? Who goes to jail then? the people with co-occurring disorders, because the treatment programs that they're being mandated to are not really addressing their needs. And so, Harvey, back to what you were saying, like when you look at, there's a big report that I can share with everybody around criminal justice, the jail system, and co-occurring disorders. More than 45% of people sitting in our jails right now have co-occurring disorders because their needs are not being met. They are then incarcerated. They come out the other side and everybody's like, oh, you've been away. You're going to do so great when you return because now you've been fully detoxed, right? You're not using anything. But if you haven't addressed the underlying causes, if somebody is returning to the environment they were in with no tools, how do we expect the recurrence not to happen? So we are building this system where we feel really good about helping people, but the people we need to help aren't getting the services they really need. I have sat in groups and conversations throughout the state of New York, and they has gone through drug treatment court somewhat successfully. And by somewhat, I mean, it's been rather circuitous. And they always talk about that moment where they finally got connected to the right therapist, the right person. And again, it's like, you should not have to get lucky. We would not accept this in physical health on any level, ever. Ratings would matter, service delivery would matter, success would matter. And so I'm going to leave myself there.
So this is really a wonderful, everybody's saying what a great panel is. I agree. You three have been on fire. Really, really a pleasure to be with
Harvey,
you.
I just want to piggyback on one thing that
No,
I
man,
think is very...
you're done. You're finished. I'm kidding. Go ahead.
No, it's actually a point that you made before, and that kind of like Stephanie's too, is that, when you talk about cahoots and we want, peers to intervene in these type of situations and not police. Again, Harvey, you mentioned earlier the importance of crisis stabilization centers in this equation. And again, in most communities, even if it's a cahoots type response, if the only options are emergency or police stations, right, that's not going to, neither one of those are really going to put someone on a path to recovery, where we need that third option in communities that provide crisis stabilization for both, mental health and substance use, that they can do detox services and mental health services, again, all voluntary, all peer-based, but that option has to be there. Or
I think we have to stop. I can't tell. Isn't it? Somebody tell me from New York whether we have to stop. Matthew, thank you. And I want to say a couple of things about government. You want to know what government can do? Government can fund community mental health and addiction services, not just with one-time only federal money either. We need a huge allocation. People are dying. People are suffering. The government needs to find the money. And the governor, God bless you, you put out $21 million last year. That's a drop into what we're going to need. And it needs to be sustainable. So thank you, Governor. But we need a lot more with that. The other thing that we're really excited about is Matthew and us and others work to pass the solitary confinement halt bill. And what that means is that a lot of the people who are put in solitary, people of color who have addiction and mental health issues. And it's a god-awful suffering. But now the people who meet that profile are going to be put in open cells 7 hours a day out where they're getting treatment. That's what government can do to really make that happen. And finally, keep an eye on 988. Which is this hotline that's going to be coming up where you can call up for help rather than you call 911, you might get a police officer. Call 988, you're going to get a mental health counselor who may actually help you move along towards Stabilization Center or some of these other alternatives. So I think we're done here. I want to thank everybody. I'm sorry you all out here couldn't see this purple shirt I got for you today. It's really quite lovely. But you weren't able to see it. So thank you, everyone, for coming. And I think for New York, you got to tell us, are we just leaving or what are we doing here? Anybody know?
Hello. Thank you again, everyone. We did have a quick question in the chat that I wanted to get to before we ended. Let me quickly go over to that. And the question is, how can we turn should be into we are? If you wanted to speak on that.
Right here with Senate Bill 5084B, okay? That is Senator Harkin's bill that passed in the last session to create a single agency. The Assembly had hearings at the end of the session in June. There was a lot of support around them sponsoring a same as bill. If you are looking at what you want to do regarding policy, we hope and pray that you recognize the value of a single agency and that you will add this to your policy statements, the rungs on your ladder and platforms to really support this. And what we're talking about here is, again, not just a merger. There are states in the United States that have Ashley, can you just mute for 1 second? That have merged agencies where they're kind of like stuck together in the same space, but they're still separate. We don't want just a single license. We want the ability to integrate fully the departments, recognizing some people have only mental health challenges, others may only have substance use disorder, but the vast majority of people are in that Venn diagram, in that gray space, and we want to make sure that we can address that appropriately.
Speaking of legislation, federal legislation is moving, but the state has a waiver application to start Medicaid 30 days before people leave prison and jail. The numbers of people with addiction that commit suicide because of a lack of health care just a few weeks out of jail and prison are astronomical. So all of us need this. It's called the Medicaid reentry measure. So people leave with health care and with help on the way out. All right, Jennifer, are we good?
Wait, I have two more pieces of legislation.
Yes.
So you can support and tell your elected officials to support S2530, okay? And that's prevention, like the overdose prevention sites. Louis, I've seen you mention it. Yes, they are so needed. We were promised pilots in 2018. We didn't get them. So also then support S1284, and that is the decriminalization of substances along with creating a task force. And so when you're advocating for this, I would ask that you advocate that task force be made up of individuals that have used or actively, currently using a substance so that there's more parity across substances than Oregon did. So those are some ways that we can ensure, right, that our policy is based off evidence rather than morality. And if anybody is interested, I can support a bunch of, we'll give you a bunch of supporting case studies and different things, because there's a boatload of countries that have overdose prevention sites. If you're interested about the heroin-assisted treatment that I was talking about.
Very last thing, Ashley and I live in Warren, Washington County. So Matthew and Stephanie, come on up. We'll buy you lunch. So thank you.
That's where my in-laws are. So I do make it up to your neck of the woods, literally woods, quite often.
So it looks
I'm always
like
up for a road trip.
It looks like Allison is here.